Nashville. And so here is the table that they constructed for the Newcorn study. So you basically have subjects assigned to either oros, atomoxetine, or placebo. And then at the overall group level, you basically see an effect size of 0.8 for oros and of 0.6 for atomoxetine. But then when they ended up breaking it down into those that were treatment naive and those who had previous treatment, you actually get for the treatment naive ones a 0.9, a previous treatment a 0.5. And you know, this is now one study. We can't like turn that into the gospel, but it's at least, I think, respectable enough to consider what's going on here. The other interesting phenomenon was that they had 44% of their sample both responding to the oros and an atomoxetine, but 34 responded to one and not the other. And then also of note, nearly a quarter didn't respond to either. You know, so even though we have a lot to offer for ADHD treatment, we still don't have something to offer for everybody. So for our later discussion, keep in mind these numbers, please. And that would move us to the new kid on the block, so to speak, the guanfacine XR, GXR in a lot of the studies abbreviated or named Intunif. They just received their FDA approval for 6 to 17-year-olds, I found this really interesting, you know, because when I was in fellowship training, we were certainly kind of instructed, and it seemed like what you expect you see, you know, clinically. Oh, the alpha agonists, they're really helpful for impulsivity and aggression, but they don't do so much for inattention. But actually, that's not really the case, and the work that has been done by Arnsten and her group, looking at what the alpha agonists might be doing, I think has definitely stimulated me to rethink this. So I thought, because it's new, we can go basic here, basic prescribing information. There are some things here that are worth considering. If we're switching somebody from regular guanfacine to the extended release, we're not supposed to be going, oh, they're on that much guanfacine now, I'm just going to convert it to that much of the extended release, because the pharmacokinetics are really different. So you're supposed to taper them off, the guanfacine, and then start them again. So that's not necessarily intuitive with Intunif, so worth thinking about. The benefits are observed at the dosages of 0.05 to 0.08 milligrams per kilogram daily. And then, based on the clinical trials, is the admonition that doses up to 0.12 milligram per kilogram may provide additional benefits, but really beyond that, no point to push it beyond that. And then when we're going to talk about dosages later, I constructed a Excel table that where we can look at, okay, so what does that actually mean? This is a situation where we're not supposed to take that with a Happy Meal or with eggs and bacon, because this probably has to do with the release mechanism. You know, that in the high-fat environment, low acidity, you get greater exposure. And then the other important thing is, of course, to taper it. This is a medication that a child who visits the parent A on the weekend and lives with parent B during the week, you know, that's the kind of child where you have to say, you can't just stop this on the weekend because this needs to be tapered down. And we have these dosage strengths here, round, long, white and green, for 1, 2, 3, and 4 milligrams. Now, the clinical trials that the FDA approval is based on consisted of 2 randomized clinical trials, phase 3 studies. They included youth 6 to 17 years. And in each case, there was also a 2-label open extension study. And it was interesting. They kind of came on the heels of each other. They conducted the first one, and if you note, the first one is described by Biederman et al. So in that study, there was a 2, 3, and a 4 milligram treatment option, and it was a forced escalation pattern. So there was no 1 milligram option, and when the data was analyzed, it seemed clear, like, especially, we're talking, there's some young children here that don't weigh that much. 2 milligrams may not really be what you want to target. So then promptly the next study had a 1 milligram option, but you could only get randomized to that if the child was below 50 milligrams because it wasn't expected that it would do anything if they were heavier. So otherwise, quite similar. And then please also note, in these open label extensions, they started out 240 children, but then there were 198 dropouts along the way over a period of 2 years. And because we were a site for both of them, you know, I had my little group of children that stayed on the intuitive, and it actually, you know, at that point it was open label, so you knew what you were dosing. It really worked, and that's why some of them stayed in there. And I guess it did not work well enough over the long haul for everybody. But dropout is a problem in any case. So in the efficacy studies, both of them, we find superiority of guanfacine over placebo. And the important insights were that you really need to look at this on a weight stratified basis. The effect sizes really varied from 0.41 in the slow dose range, 0.01 to 0.04, up to an effect size of 1.34 in the high dosage range here. And note that in the FDA approval, that dosage range isn't really recommended. But if you wanted to think about where do we have safety data, we do have safety data for this dose range. And you see also the clinical global impression response rate goes up with the milligram per kilogram dosing. When we work with this medication, keep in mind that because you have to work up to the right dosage, benefits will not start immediately. That's different from the stimulants. And now, on the other hand, the benefits can last longer than 8 hours, and they're not going to interfere with sleep. So that can be quite a benefit, lasting 8 to 14 hours and possibly longer. Pretty clearly, children seem to have better responses than adolescents, and likely that is a weight-based dosing phenomena to some degree, because you are not going to be pushing adolescents up to these dosage levels that a child can get to. Yeah, this is just graphically showing the efficacy data. So we see, of course, the placebo responses to medications, but you see a separation, and this is showing the effects by pill strength. And then this is copied right out of the paper by Sally et al. So this is showing you the effects here by pill strength, and here by dosing, weight-based dosing. And this is the reason why in the FDA approval, you basically have this admonition that doses, you know, above 0.08 can provide additional benefit, but you don't see this one appearing. In the open label studies, we get reports that you have significant reductions from baseline to endpoint, that these reductions were apparent at 1 month and were sustained for 2 years. We're just keeping in mind that the rate of dropout was high. And tolerability, I think, is a bigger story here. You know, because with this medication, we already know from the clinical experiences with clonidine and guanfacine per se that you're now looking at a profile of potential sedation and somnolence and fatigue, or they call it the SSF